So, very good morning. Today we'll be having a class on gingival diseases in childhood and acute gingival diseases. To start with, we'll see at the end of this lecture, we would like you to know three common gingival diseases which occur in children, explain the various gingival diseases in children, differentiate the normal gingiva from the gingival diseases which occur in children, and recognize various clinical features of gingivitis. So the contents of this particular lecture would include gingival diseases in childhood, which will include introduction, periodontium of the primary dentition, periodontal changes associated with normal development, gingival diseases of childhood, periodontal diseases of childhood, gingival manifestation of systemic diseases in children, and then we'll finish it with a summary. So to start with, it is postulated that periodontal disease in adults is at least in part precipitated by the gingival inflammation in the formative years of childhood and early adolescence itself. So, non-destructive gingival inflammations of childhood without appropriate intervention, it could result in significant periodontal diseases. In other words, if there are diseases which are noticed in childhood, if you are giving them proper treatment at the childhood itself, it could result in reduction of diseases in the adult population. Exchange of dentition from the primary to permanent and the hormonal changes associated with puberty offers a unique condition in the periodontal changes and also the ability of the structures to resist the destructive changes. Therefore, after reviewing the anatomic and physiologic changes in the periodontium and dentition, this discussion presents the periodontal problems associated with the childhood and adolescence. So there is always a difference between the children as well as the adult periodontium. So what are the differences? We'll just go about. So in case of children, the marginal gingiva is round, thick, rolled, flaccid and retractable, whereas in case of adult, it is a knife-edged marginal gingiva. It is also seen that the marginal gingiva is just broad buccolingually and narrow mesiodistally. This is mainly to conform to the morphology of the deciduous dentition. Next, coming on to attached gingiva. The attached gingiva here in case of children is wider than that seen in the adults and it is less stippled. So in other words, stippling starts in generally after 3 years of age. It is less dense and redder in color. There are two unique features which are seen in the primary dentition. That is the primary periodontium, which are known as the interdental clefts and the retrocuspid papillae. In case of adults, the attached gingiva is more stipple and it's more coral pink in color. Next, coming on to the papillary gingiva, that is the area which is there in between. There is no interdental caul formation as seen in that case of the adults. So since there is no caul formation, this area is less susceptible to infections. Whereas in case of adults, there is a pyramidal or a caul formation, caul shape, which is present in between the teeth, and therefore this is formed as a saddle where the food gets accumulated, and this area is more susceptible to infection. Gingival sulcus. Gingival sulcus, the depth is shallower in case of the children. It is just 1.4 to 2.1 mm. Whereas in case of adults, it is a little deeper. It's 2 to 3 mm in size. You can also see in the radiographs that there is the lamina dura is prominent with a widened PDL and the crusts are within 1 to 2 mm of CEJ. Next, coming on to the periodontal changes associated with normal development. So normally these changes could occur in the periodontium of children, but don't consider that to be a disease status. Just wait and watch for these conditions. So one such condition is your pre-eruption bulbs. This occurs before the eruption of the permanent tooth. The gingiva becomes bulged, that is firm, and it may be either pink or blanched. This eruption cyst is mainly filled with blood and it just occurs before the eruption of the permanent teeth. Just remember that. This may be either bluish or deep red enlargement may be present of the gingiva over the erupting teeth. It mostly occurs in the lower incisors or the molar regions. Next, coming on to primary tooth exfoliation. Mainly this occurs in children where there is a decrease of the gingival sulcus the depth and there is an increase in the depth of gingival sulcus and the junction epithelium migrates down the resorbing root of an exfoliating tooth and therefore the tooth becomes mobile and the tooth gets exfoliated. Next, coming on to malocclusion. Again, trauma of the periodontal structures could be there if there is going to be a malocclusion present. plaque and food removal may be difficult with it, gingival enlargements and pseudo pockets could occur. Wait and watch, and then consider discussing the case with a periodontist as well as an orthodontist if any intervention could be done at this particular stage. Next, coming on to gingival diseases of the childhood. So now we are coming to the disease part. So till now it was in normal parts which we are seeing. So this could be of two types. It could be either the plaque induced or it could be the non-plaque induced. Plaque induced includes your gingivitis, eruption gingivitis, pubertal gingivitis, drug induced gingival enlargement, gingival changes related to orthodontic appliances and mouth breathing, whereas non-plaque induced relates to your primary herpetic gingival stomatitis and your candidiasis. Now first coming on to the chronic marginal gingivitis. So this is just the same as that of the adults, but you would not expect such situations in children, that is very disease status as that found in the adults. Here it presents as a red linear inflammation which is accompanied by underlying chronic changes including swelling, increased vascularization and hyperplasia. Bleeding and increased pocket depth are not found as often in children as seen in the case of adults. Coming on to pubertal gingivitis. So the word puberty itself shows that it occurs in and around the age of puberty, that is around 11 to 13 years of age. And why it occurs, we do have an etiology for this, and if you write this etiology in form of a flow chart, or if you present things in form of a flow chart, it is easy for the one who is reading, and it is also easy for you to understand. So I have presented this in form of flow chart for you to understand it better. So generally pubertal gingivitis, why does it occur? It is seen that during the pubertal time that there is an increased level of estrogen and progesterone. Because of this, there is an increase in the blood flow to the gingiva, and this raises their sensitivity and reaction to the irritants. Not only that, you do have gram-negative anaerobes such as Prevotella intermedia, which is an ovarian hormone which acts as a substitute for vitamin K growth factor. Apart from this, you do have the other microorganisms such as Prevotella nigrescens, Capnocytophaga and motile rods and spirochetes present. So all this results in inflammation of the gingiva, that is reaction to the irritant becomes more, and therefore gingival inflammation occurs, and therefore gingivitis occurs. This generally occurs between 11 to 14 years of age. Because of exaggerated response to local factors, the inflamed tissue becomes erythematous, lobulated, retractable, feels tender and bleeds easily. So how do you differentiate a pubertal gingivitis from a normal gingivitis? So these 5 factors play a major role in differentiating them. So all these 5 factors together combined shows that, along with the age and the clinical history, shows that this could be a pubertal gingivitis. Histologically, there is inflammatory hyperplasia which is seen. There could be even gingival enlargement. The Capnocytophaga species which is seen in these conditions have shown that they are the reason for increased bleeding tendency. Next, coming on to drug-induced gingival enlargement. As seen in the adults, it is the same, that the cyclosporin, phenytoin and the calcium channel blockers which are used to treat the conditions that are encountered results in drug-induced gingival enlargement. And next, coming on to gingival changes related to orthodontic appliances. This complicates the plaque removal. So we ourselves as adults, if we do have brackets or braces which are present, it is difficult to clean those areas. So just imagine children, and therefore be little cautious when you are applying the brackets and bands to the children. So this complicates the plaque removal. Gingival changes can occur within 1 to 2 months of the appliance placement, and therefore it is important to educate the parents. Next, coming on to mouth breathing. So mouth breathing and lip incompetence together results in open mouth posture, a posture like this. This may be associated with increased plaque and gingival inflammation, especially in the anterior area. Next, coming on to primary herpetic gingival stomatitis. So this is common in children. The symptoms develop suddenly, where there is headache, fever, malaise, irritability and pain with intake of food and liquid of acid content. This is characterized by a fiery red gingival tissue. The oral findings is of white or yellow liquid, which liquid filled vesicles, which in few days these vesicles may rupture to form painful ulcers. So here is a condition where that's a painful ulcer. These ulcers may be 1 to 3 mm in diameter, which are covered with a whitish or a grey membrane, which is with circumscribed area of inflammation. Next, coming on to periodontal diseases of the childhood. So the incidence is around 12 to 17 years of age, and the prevalence of severe attachment loss involving multiple teeth remains low at a rate of 0.2 to 0.5 percentage. Coming on to the localized aggressive periodontitis, so this generally occurs in and around the pubertal age. So here you could see that there is an interproximal attachment loss which is seen at least on 2 permanent teeth, which includes your first molar region. So you can see all the molars are being involved and the incisor region. So the 2 permanent teeth, if it is involved, if there is interproximal attachment loss, then we consider a provisional diagnosis of localized aggressive periodontitis, especially if it occurs in children. Apart from this, you do have another class on aggressive periodontitis where we would be taking a little brief about it. Signs of bone loss around the teeth during the primary dentition suggest aggressive periodontitis. Generalized aggressive periodontitis, where there is generalized interproximal attachment loss, including at least 3 teeth that are not the first molars or the incisors. This may be associated with Down syndrome. Chronic periodontitis, there may be slow to moderate rate of progression that may include periods of rapid destruction. This is little less prevalent in children. In other words, it's more common in the adults. Next, coming on to gingival manifestation of systemic disease in children. Acute necrotizing gingivitis. This is a rare condition. It could be because of primary or secondary immune suppression. It could occur in Down syndrome, severe malnutrition cases. The child's breath is fetid and it complains of pain and discomfort when eating. Endocrine disorders and hormonal changes. Insulin dependent diabetes mellitus is one of these conditions. This occurs more frequently in children and in young adults. It includes premature tooth loss. This is mainly encountered with impaired immune response to the oral flora. Severity exists, especially it results in worse condition in children with poor metabolic control. Hematologic disorders and immune deficiencies such as leukemias, leukocyte disorders, congenital anomalies such as Down syndrome, all these do have certain gingival manifestations present, and these are mainly because of the systematic changes. So to summarize, the periodontium of the primary dentition differs from that of the permanent dentition. Normal development can result in changes into the periodontium. Plaque-induced gingivitis is very common in children, although it may be less intense in the adults. With the exception of the localized aggressive periodontitis, children rarely show signs of periodontitis. Some systemic disorders commonly associated with periodontal disease present initially during the childhood. Recommendations regarding home plaque control routines should be individualized according to each patient's periodontal disease status and developmental stage. Okay, moving on to the second part of the lecture, that is your acute gingival diseases. So from this lecture, we would expect you to name at least 5 acute conditions of gingival and periodontal disease. Identify the etiology for each acute gingival disease. Describe the clinical features of acute gingival disease. Categorize different treatment procedures for all acute conditions of gingival diseases. So to start with the contents, we would be discussing about abscess, which would include your gingival, periodontal and pericoronal abscess. Necrotizing periodontal disease, which will include your necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis, and gingival disease of viral origin, which will include your recurrent herpes abscess ulcers. It is a localized purulent infection that involves the marginal gingiva or the interdental papilla. The main etiology being it is acute inflammatory response to a foreign substance which is forced into the gingiva. So this foreign substance could be either an apple skin which is present, or it could be either the toothbrush bristle. So if it gets stuck on the gingiva, it just forms a localized swelling on the marginal gingiva or papilla, which is filled with pus. Initially, it is a red swelling with smooth shiny surface, but within 24 to 48 hours it becomes fluctuant and pointed with a surface orifice which is known as purulent exudate. This may be painful. Adjacent teeth may be sensitive to percussion. There could be no previous history of periodontal disease in such teeth. So the main treatment is just the elimination of the foreign object will be enough. Drainage through the sulcus with probe or light scaling would be sufficient. Follow up after 24 to 48 hours is needed. Next, coming on to periodontal abscess. This is a localized purulent infection which occurs within the tissues adjacent to the periodontal pocket that may lead to destruction of the periodontal ligament and alveolar bone. It is otherwise called as a lateral abscess or the parietal abscess. So the difference between periodontal abscess and gingival abscess: in case of periodontal abscess, the hint is that you will be having a pocket along with it. Okay, whereas in case of gingival abscess, you will have a history of a foreign object being stuck. This could be the infection to the periodontium resulting in periodontal abscess could be through one of these following ways. There could be an extension of infection from periodontal pocket deeply into the supporting periodontal tissues through the lateral aspect of the root. There could be a lateral extension of the inflammation from the inner surface of the periodontal pocket into the connective tissue of the pocket wall. There could be formation in pocket with a tortuous course around the root. During incomplete removal of calculus during the treatment of a periodontal pocket could result in a periodontal abscess called as a post-scaling abscess. It could be after trauma to the tooth or with perforation of the lateral wall of the root in the endodontic therapy. So it is accordingly divided based on the location as abscess in the supporting periodontal tissue along the lateral aspect of the root, or it could be abscess in the soft tissue wall of the deep periodontal pocket. So signs and symptoms of periodontal abscess, especially if it is an acute abscess, you will be having mild to severe discomfort. There could be a localized red ovoid swelling, periodontal pocket, mobility, tooth elevation in the socket, tenderness to percussion or biting, exudation, elevated temperature, or a regional lymphadenopathy could be present. So these both are more of systemic signs which are shown. Whereas chronic abscess, there would be no pain or dull pain could be present, and there would be localized inflammatory lesion. There would be slight tooth elevation, intermittent exudation. Fistulous tract often associated with a deep pocket could be present. It is usually without any systemic involvement. So how would you differentiate a periodontal abscess from a periapical abscess? So just remember, always periodontal abscess, the periapical abscess goes with a non-vital tooth, whereas periodontal abscess goes with a vital tooth. Periodontal abscess, the teeth necessarily need not have any caries present, whereas periapical abscess could have a caries tooth or it would be a non-vital tooth. Periodontal abscess, if you diagnose it to be a periodontal abscess, it has to have some pockets present because the disease spreads from that area. But in case of periapical abscess, there is no pocket present. There could be mobility in case of periodontal abscess. There could be no or minimal mobility in case of periapical abscess. Percussion sensitivity may be variable, whereas here the percussion sensitivity will be present. The sinus tract opens via the keratinized gingiva here, whereas here the sinus tract opens via your alveolar mucosa. So you can see the differences between all the three abscesses. So what are the treatment options for periodontal abscess? It could be drainage to the pocket retraction to the pocket, either by a retraction or by means of incision, scaling and root planing, or by doing periodontal surgery, or with the help of systemic antibiotics. If very severe, then we can go in for tooth removal, provided if the tooth is mobile and it has a hopeless prognosis. Next, coming on to the indications for antibiotic therapy in patients with acute abscess. It could be you can use or prescribe antibiotics if the patient has cellulitis, deep inaccessible pocket where scaling is not possible or root planing is not possible, fever, regional lymphadenopathy, or an immunocompromised patient. Antibiotic options which are available for periodontal infections are amoxicillin 500 mg, 1 gram loading dose, then 500 mg 3 times daily for 3 days, reevaluation after 3 days again. Penicillin, if the patient is allergic to penicillin, then you go in for clindamycin or azithromycin. Next, coming on to pericoronal abscess. So this is a very common condition which we do encounter in the clinics, especially in the age group for around 18 to 25 years. So that is the time when the tooth erupts, the third molar erupts. So you do get problems during that era. So in case of this pericorneal abscess, it is a localized purulent infection within the tissue surrounding the crown of a partially erupted tooth. Sorry for the interruption. So pericorneal abscess, it is a localized purulent infection within the tissue surrounding the crown of a partially erupted tooth, especially the mandibular third molar areas. So this forms as inflammatory fluid cellular exudate on the flap that is just above the third molar area, especially in impacted tooth. So generally when this the food substances gets engorged between the flap as well as the tooth, it results in infection in this area. So this infection projects itself as an increase in the bulk of the flap. So this, when it is filled with abscess, it is called as an pericorneal abscess. This might interfere with complete closure of the jaws. It may be traumatized by contact with the opposing jaw, thereby aggravating the inflammatory involvement. So this appears as a red swollen suppurative lesion which is tender and radiating pains to the ear, throat, floor and the mouth. There is a foul taste and trismus may be present. The swelling of the cheek, and there may be also swelling in the region of the angle of the jaw as well as the lymphadenitis. Fever, leukocytosis and malaise are other conditions which are seen systematically if the abscess occurrence. Next, coming on to the treatment option. The first and foremost treatment option is to debride the area which is there between this pericorneal flap. So only if you are going to remove all the local irritants such as food deposits from the area beneath this flap, then only the infection will subside. Or you can contour after this first procedure. You can go in for contouring of this area, that is just removing of the tissue flap. Or you could also go in for extraction of the tooth or involved tooth or the opposing tooth. Since they are third molars, it is generally advised as a permanent solution. You can also go in for antimicrobials since there is an abscess, either local or systemic. Culture sensitivity, based on the culture and sensitivity, and a follow-up is required. Sometimes a distal molar surgery could be carried out, where if there is a tissue which is present along with the pocket depth, then you can go in for excision of this entire tissue, where you can see very clearly that the entire tissue is being removed out and thrown out, and this area is made self-cleansable for the patient. So there could be complications in patient if this particular pericorneal abscess is not being solved, such as peritonsillar abscess, cellulitis and Ludwig's angina. Next, coming on to necrotizing periodontal diseases, necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis. So this is an infection characterized by gingival necrosis, and this has the characteristic punched out papilla with gingival bleeding and pain. This is otherwise known as Vincent's disease and trench mouth disease. The necrosis is limited to the gingival tissues comes under the term necrotic ulcerative gingivitis. It is estimated to have a prevalence of around 0.6% in the general population, with young adults being the main target population. Bacteria floral, which is seen here, are the spirochetes, the Treponema species, as well as the fusiform bacteria and the Prevotella intermedia. Clinically, you could see that there is a little amount of gingival necrosis which is taking place at the tips of the interdental papilla, and this is termed, again to reiterate, that it is punched out crater-like depressions which are seen at the crust of the interdental papilla. There could be gingival bleeding, pain, fetid breath, along with pseudomembrane formation. Predisposing factors such as emotional stress, poor oral hygiene, cigarette smoking, poor nutrition, and immunosuppression could be other predisposing factors. Necrotizing periodontal diseases are common in immunocompromised patients, especially in those who are HIV positive or having acquired immunodeficiency syndrome. Necrotizing ulcerative periodontitis, on the other hand, is necrosis and ulceration of the coronal portion of the intestinal papilla and gingival margin with a painful bright red marginal gingiva that bleeds easily. So this has included more of the periodontal structures, unlike the gingivitis. Here there is a destructive progression of the disease involving the periodontal attachment and the bone loss. Here, as found in the case of periodontitis where there is conventional periodontal pockets, here in case of necrotizing ulcerative periodontitis, you don't have conventional periodontal pockets or deep probing depths which are present. This is because the necrosis of the junction epithelium in the patients with nug or nub creates an ulcer that prevents the epithelial migration, and a pocket formation cannot occur. Only if there is epithelial migration, a pocket formation can occur. Since there is necrosis of the whole area, the epithelium itself, the migration doesn't take place, and therefore pocket formation doesn't occur. Next, coming on to treatment, you could do a local debridement. Most cases are adequately treated by debridement and scaling and root planing. Anesthetics are needed for this condition. Consider avoiding ultrasonic instrumentation due to the risk of HIV transmission. Oral hygiene instruction, oral rinses such as chlorhexidine, hydrogen peroxide, and providone iodine is required. Pain control or antibiotics with antimicrobials such as metronidazole to be taken. Modify the predisposing factors. Follow up and frequent cases occur due to the condition until the resolution of the symptoms. Comprehensive periodontal evaluation is required following the acute phase. Next, coming on to gingival diseases of viral origin. Acute manifestation of viral infections of oral mucosa characterized by redness and multiple vesicles that easily rupture to form painful ulcers affecting the gingiva. This could be either recurrent herpes or recurrent aphthous ulcers such as minor, major or herpetiform ulcers. Next, coming on to recurrent herpes. This could otherwise known as fever blisters or cold sores. This is usually a infection that is just a latent infection where the viruses reside in the trigeminal ganglion, and then through the neural passage of the virus, if there is going to be any predisposing cause, then it results in ulcers in the oral cavity. These oral lesions usually are caused by the herpes simplex virus type 1. Recurrent infections can occur in 20 to 40% of the cases. With primary infection, herpes labialis is common. Recurrent infections are less severe than that of the primary. Clinical features: prodromal syndrome is present, such as fever and other conditions. Lesion starts as vesicles, ruptures and leaves the ulcers. A cluster of small painful ulcers on the attached gingiva or the lip is a characteristic feature. It can cause post-operative pain following dental treatment. The virus generally gets reactivated from the trigeminal ganglion due to certain conditions such as fever, systemic infection, UV radiation, stress, immune system changes, trauma, and unidentified causes. Coming on to the treatment: palliative treatment, antiviral medications considered for treatment for immunocompromised patients but not for periodic recurrence in healthy patients. Recurrent abscess stomatitis is also known as canker sores. The etiology is unknown. Prevalence is around 10 to 20% of the general population. It usually begins in the childhood. Output breaks sporadic, decreasing with age. Clinical features include it affects mobile mucosa, most common oral ulcerative condition. There are three forms: minor, major, and herpetiform ulcers. So the difference between all three of them, as the name suggests, minor ulcers, they are just most common, and these are small shallow ulcerations with raised erythematous borders. The central area is covered with yellow-white pseudomembrane. It heals within 10 to 14 days without scarring. Whereas in the case of major ulcers, it usually larger than 0.5 centimeter in diameter, persists for many months, frequently heals with scarring. Herpetiform ulcers, small discrete crops of multiple ulceration. Lesions are similar to herpetic stomatitis, but there are no vesicles. It heals within 7 to 10 days without scarring. Predisposing factors may be present. So the treatment for this is palliative. Pain relief, topical anesthetic rinses are given, adequate fluids and nutrition, corticosteroids, oral rinses, topical band-aids, chemical or laser ablation of the lesions can be done. Allergic reactions do occur in the oral cavity. So higher concentration of allergen required to cause allergic reactions in the oral mucosa than in the skin or the other surfaces. For example, dental restorative materials, mercury, nickel, gold, zinc, chromium and acrylics, toothpaste and mouthwash, flavor additives like cinnamon or preservatives, foods, peanuts or red peppers could cause allergy. Clinical features are variable. It resembles the oral lichen planus or the leukoplakia features. Ulcerated lesions may be present. Fiery red erythematous gingivitis could occur. Treatment is a comprehensive history and interview regarding the condition. Lesions will resolve generally after elimination of the offending agent. So to conclude, the diagnosis of the acute gingival infections can be made on the basis of the clinical presentation. Differential diagnosis must be sought out for the various conditions. Treatment must be directed towards alleviating the pain with control on the spread of infection. So any questions you can ask through the Google Classroom.